Thank you, Tony. Our next presentation will be from Dr. Bettina Husebø, who is the leader of the Center for Elderly and Nursing Home Medicine, part of the Department of Global Health and Social Medicine at the Faculty of Medicine at the University of Bergen. And she'll talk specifically about digital phenotyping in patients in nursing homes, including those with dementia, disadvantages and advantages. Thank you so much.
Thank you, Gary. Dear all, let's start with greetings from Norway. In summer and winter, by day and by night. And this is the polar light in the north of Norway in wintertime. And this is my patient from the nursing home, Bergen. Several years ago, he developed a stroke and severe dementia. He is paralyzed on the right side of his face, and he lost his speech ability. In addition, he has neuropathic pain in his right shoulder. When he feels this pain and he is not able to express it, he is developing agitation, depression, sleep, and eating disturbances. Bjørn is a typical patient in a Norwegian nursing home. We have 900 nursing homes for 5 million inhabitants. This means that 14% of those older than 80 years are living in a nursing home in Norway. Here we are on the top worldwide. Most of these people have dementia and behavioral disturbances and multi-morbidity. Half part of the Norwegian dying society is deceasing in a nursing home. Only 6 to 15% are dying at home. And here we are on the bottom worldwide, despite the fact that most of us would prefer to die at home and to stay there as long as possible. Multimorbidity combined with dementia is leading to polypharmacy in nursing home patients. On average, every Norwegian nursing home patient receives 8 or more regular drugs. Almost 40% receive antidepressants with questionable results. More than 41% receive 2 or more psychotropic drugs with considerable side effects. People also receive analgesics. The number of analgesics increased from 35% in 2000 to almost 60% in 2011. But this does not mean that people get better pain assessment or pain treatment because we use so much pain medication. Our research group developed and tested the MOBI-2 pain scale for people with advanced dementia who are no longer able to express their suffering. This is a 2-part pain assessment instrument developed for nursing home staff, where the first part of the instrument is assessing pain, which may be related to musculoskeletal system. Part 2 assesses the pain, which may be related to internal organs, head and skin. It's easy to learn, implemented in nursing home and translated to different languages. It is also tested related to reliability, validity, and especially to responsiveness. And this means that we are able to use this instrument in clinical studies. And indeed, we did, including 352 people with advanced dementia and agitation in a cluster randomized controlled trial. We investigated the efficacy of individual pain treatment on agitation in people with dementia. And we found, compared to the control group, a significant effect of pain treatment on agitation in week 4 to 8. And this effect diminished in the washout period. Pain treatment did not only have a significant effect on agitation, but also on depression and sleep disturbances. But it's still a question, what is pain? what is agitation and what is depression? Or is it even grief or apathy in these people? This is Caroline, and she said, I receive these pills because they want me to stop crying because my husband died. To learn more about the efficacy and tolerability of opioids in people with dementia, and to learn more about the pain, depression dyad, we recently finalized a placebo-controlled trial, Dependem, including people with severe dementia. Interestingly, and against our hypothesis, we recognized that people with dementia do often not tolerate morphine, and they dropped out of the study, especially when the morphine was combined with antidepressants. This was really astonishing for us, and we got a lot of attention related to this and conducted, together with Professor Ipsit Vahia, a systematic review on this topic. We also got attention from The Guardian because they say painkillers used for dementia could make symptoms worse. And this was really the fact we found, because people had more agitation and more confusion in the intervention group. So, pain assessment and pain treatment is an important topic in the nursing home, but it's not the whole story. We need better advanced care planning in communication with these people. We have to ask what matters to you. We need less medication, so there is a high need for systematic medication review, and they need more activities. And this was a starting point for a comprehensive, multi-center, cluster randomized trial, the COSMOS trial, to improve the quality of life for people with dementia in nursing homes. We included almost 800 people from 37 nursing homes all over Norway and implemented this multi-component non-pharmacological intervention. And we educated 10,000 healthcare workers in nursing homes. And what we found was people are old, usually female, they have a lot of diagnoses, they have pain, they have PTSD, and compared to the control group, the intervention group had better quality of life, less depression, less agitation, staff was less stressed, and they had better appetite and better ADL functioning. So, these studies are related to the Center for Elderly and Nursing Home Medicine at the University of Bergen. We are working with research, education, implementation of research results, and national and international collaboration to improve the lives of our patients, their relatives, and the staff. Our center is financed by the Norwegian government, which in the last years had a high focus on nursing home research. But for the last 2-3 years, they increased the focus on e-health and technology and innovation for people living at home. And here we are. There is a new generation of elderly people. This is Yurin. She is almost 90 years old and on Facebook with her 15 grandchildren and 9 grand-grandchildren. And she made her decisions. She wants to stay at home, she wants to die there, and she wants to avoid dementia. So, she is actually following the latest recommendations from the World Health Organization about risk reduction of cognition and dementia, which encourage us that we should decrease the risk in our population. This is an amazing article from the Lancet Commission by Livingstone et al. And they recommend that we should take action before cognitive decline and dementia is a fact. And they say that by education, by activities, mental, social, physical, family contact, voluntarism, purpose, meaning with life and spirituality, healthy diet, no smoking, less alcohol, and some medical issues can reduce the risk for dementia with about 35%. Taking this into account, and together with about 18 companies and national and international researchers, we recently applied for a Center for Research-Driven Innovation to predict, prevent, and to support people with age-related neurological diseases. This application includes the development of biomarkers and big data sets, visualization, recommendation of lifestyle approach, and smart housing and smart living. And one of our collaborators is Professor Ipsit Vahia, who participated actively in this application. And he visited us last summer, and I have nice greetings from him and a very brief movie for you. Please.
Dementia is possibly the biggest public health issue in the world, period. McLean is the #1 ranked psychiatry hospital in the United States, and my personal research work centers around using new technologies in the care of older adults. Because people with dementia require constant oversight, this ends up being a challenge that is very resource intensive and as a result very expensive. So the direct costs of dementia care in the United States and likely worldwide are about the same as the cost of heart disease and almost 20 to 30% higher than the costs of all cancers combined. We're looking at how technologies can be used to monitor behaviors in a way that is non-intrusive, minimally demanding of patients and the healthcare infrastructure, protects people's privacy and confidentiality, but also generates key data that can help us identify changes in behavior, changes in sleep, changes in things like agitation or depression or apathy. It will simplify the process of keeping track of how people do on a day-to-day basis. We do know some factors that can certainly reduce the likelihood of dementia. A big one is ongoing activity, brain activity late into life. The brain needs to stay active and engaged the way the rest of the body does. And I think in the same way that we encourage people to exercise so they can stay fit because it's good for their body and physical well-being, we are now beginning to understand that remaining intellectually active and maintaining a sense of purpose, a reason to wake up every morning, may be just as important. I'm here in Norway as a collaboration with Professor Husebø at the University of Bergen. I think the university is doing path-breaking work around how to manage care in nursing homes and in the context of dementia. So I expect that this will be a project with global healthcare ramifications and global importance. And I think the lessons we learn, it will be huge for the Norwegian population, of course, but I think it has the potential to inform care, to inform training, and to inform policy worldwide.
Thank you, Ipsit. So let's continue briefly. There are several challenges to resolve because when we are doing our research on people with complex chronic conditions, we need complex clinical trials, user involvement, and multidisciplinarity. And we usually use traditional measures with proxy rating. However, we know that there are a lot of limitations because these measurements have often low validity. It's costly. We need large sample sizes over a long time. And we have to manage that we need real-world data, that we have objective measures, and that we combine these real-world data with our clinical data. But real-world data has also their limitations because we do not yet know about the clinical decision-making process. We do not know enough about the visualization, and we perhaps lose the learning effect by staff when we are using these more clinical data and digital phenotyping. In addition, we have to overcome ethical challenges. First, we have to include patient-public involvement. We should not do our research about them, but with them. A lot of people are engaged in these studies, but all of these people should be addicted to responsible research innovation. In addition, and this is typical for Europe, we have the General Data Processing Regulation. In one way, it's difficult to achieve. In the other way, it gives us a possibility to include people with severe dementia in clinical studies. And in addition, we have the Data Protection Impact Assessment. So it's all about people. And I hope that we can have a fruitful discussion about method development to combine clinical studies and digital mental health. We need it in the real-life setting. And then we need these data for symptom management, not only assessment of the symptoms. And last but not least, elderly care is a women's affair, and we welcome all the men to participate in elderly care. Thank you so much.